Hi, class. Welcome back. It's Dr. Lindner. We're still looking at neurology. Now we're going to be looking at um, the spinal nerves and some of the plexi. Please bear with me. For some reason, there's a little bit of a dysfunction with the PowerPoint where the the page just shows 3 times. So after this, I will advance, and it typically goes back to the same slide a few times. So just bear with me, okay? So one of the things to keep in mind is that when we talk about the spinal cord, we know that the spinal cord starts somewhere um, between right under the occiput through the magnum foramen, goes down and ends somewhere around L1, the L1, L2 interspace. Okay. But in terms of spinal nerves, there are 31 pairs of spinal nerves. There are 24 vertebrae, right? We have 7 cervicals, 12 thoracic, 5 lumbar. When you add up 7, 12, and 5, you get 24 freely movable vertebrae. But in terms of the spinal nerves, there are 31 pairs. There are 7 cervical vertebrae, but there are 8 pairs of cervical nerves. There are 12 pairs of thoracic nerves. There are 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of coccygeal. And when we add them up, you get 31 pairs of sensory and motor nerves. You'll also see on the left-hand side there, we've got a cervical plexus, which goes from C1 to C5 nerve roots. We have a brachial plexus, C5 to T1 nerve roots. There's no plexus in the thoracic region. These are just intercostal nerves, meaning nerves that go between the ribs to the intercostal muscles. Then in the lower back, we have a lumbar plexus, L1 through L4 nerve root, and a sacral plexus, which goes from L4 to S4 nerve root. So it'll be important to know these 1, 2, 3, 4 plexi, to know the nerve roots, and to also focus on the main nerves that come off of each. So in terms of the cervical plexus, I'll focus on the phrenic nerve. On the brachial plexus, we'll focus on these 5. On the lumbar plexus, it'll be important to know the lateral femoral cutaneous nerve, femoral and obturator. And under the sacral plexus, it's important to know the sciatic nerve, which is made up of the common peroneal and tibial nerve. Okay. So in terms of the connective tissue covering around nerves, it's kind of similar to what we had when we covered muscle. Remember when we did muscle, it was an endomysium, perimysium, and epimysium. Now with the nerve, we have an endoneurium, perineurium, and epineurium, but the concept is exactly the same, right? We have an axon, and then we have an endoneurium that surrounds that. Then you get a cluster of those, right? And it forms a fascicle, and a perineurium surrounds that. And then we get a group of those surrounded by an epineurium all the way around, covering the entire nerve. So we have the endoneurium, perineurium, and epineurium. You can see them here as well, right? You have the endoneurium surrounding the axons. Then we can see a bunch of fascicles, right? This is a fascicle. And we have a perineurium surrounding that. And then when you get a bunch of those fascicles, they'll be surrounded by an epineurium. Let's look at some of the branches of a spinal nerve. So shortly after passing through the IVF is the intervertebral foramen, which is this space right here. When one vertebrae is on top of the other, there's this foramen or hole in which the spinal nerve exits on both sides. So shortly after the intervertebral foramen, a spinal nerve divides into several branches. So let's take a look at some of these branches. You should be familiar with the dorsal ramus and the ventral ramus. Okay. Now, the dorsal ramus goes dorsally, it goes to the back, it goes to the skin of the back and some of the back muscles. The ventral rami is much thicker. And the reason why the ventral rami is much thicker is because it's the ventral rami that form the plexi, whether it's the cervical, the brachial, the lumbar, or the sacral plexus, they form the plexi. That's why they're so thick. These are always motor. Okay. What else do we have back here? We have the meningeal branch right here that will supply the meninges, the vertebrae, and the blood vessels. Okay, so those are kind of the biggies. You'll see back here these filaments. These are called the dorsal rootlets, and these are the ventral rootlets, right? So the dorsal rootlets are here, but this is the dorsal root. These are the ventral rootlets. This is the ventral root. And that's why the spinal nerves have sensory and motor, right? There's two components to that. All right, when we talk about a nerve plexus, it's the joining again of the ventral rami. All the ventral rami are going to create the plexus. In the neck, there's a cervical and a brachial plexus, and in the lower back, there's a lumbar and a sacral plexus. There is no plexus in the thoracic region. It's just that we have 12 pairs of intercostal nerves that will innervate the intercostal spaces where we have the intercostal muscles. So here is just a good picture of the neck where we can see both the cervical plexus and the brachial plexus. Cervical plexus is about C1 to C5, and then the C5 is kind of like a shared level because from C5 to T1 is the brachial plexus. And you can see that there's a bunch of nerves that come off the cervical plexus. And here it's showing a few nerves that come off the brachial plexus. We'll probably focus a little bit on that phrenic nerve right there. So the cervical plexus, it's from the ventral rami of C1 to C5 nerve roots, and it supplies parts of the head and the neck and the shoulder. And the big one to be familiar with is that phrenic nerve, which comes from C3 to C5. So I like to say C3, 4, and 5 keep the diaphragm alive. C3, 4, and 5 keep the diaphragm alive. The phrenic nerve goes to the diaphragm. There could be damage to the cord above C3, which can cause respiratory distress, because above C3, we have C1 and C2 vertebrae, and that's where the medulla oblongata is, and that's also where the vagal nerve or cranial nerve 10 nuclei exists. And that nerve goes to the heart and to the lungs. So if there's damage here, and it's also the level of the medulla is the cardiac center and the lung control center. So if there's damage to C1 and C2, especially from birth or birth trauma, that can create damage to the medulla or damage to the vagal nerve. There could certainly be cardiac or respiratory issues. When a baby's being pulled out of the vaginal canal during delivery, there could be stretching, right? Tractioning of this, which could damage the phrenic nerve, which can affect the breathing. So I do have another video on birth trauma, and please make sure you take a moment to look at that. Okay, so this just shows the phrenic nerve, and we can see that C3, 4, and 5, when we follow that up, that's C3, C4, and the C5 level gives rise to the phrenic nerve. C3, 4, and 5 keep the diaphragm alive. Let's look at the brachial plexus. Brachial plexus are from the ventral rami of C5 to T1. So that means C5, C6, C7, C8 nerve root, and the T1 nerve root. Now, there are only 7 cervical vertebrae, but there are 8 cervical pairs of cervical nerve roots. That's because the C1 nerve root exits between the occiput and the C1 vertebrae. So there are 5 terminal branches, 1, 2, 3, 4, 5. The axillary nerve, the musculocutaneous nerve, the radial nerve, median nerve, and ulnar nerve that are the terminal branches of the brachial plexus. And each of these nerves control muscles of the upper extremity. Now, from the neck, pay attention, you'll see that the nerve roots, although the nerve roots start up here in the neck, they go down underneath the clavicle. And then don't forget, we're going to have the pectoralis muscle that comes here. So the pecs are superficial, and the brachial plexus goes under the clavicle and under the pec minor muscle. So if there are any issues, or even if someone has a cervical rib, that can compress the brachial plexus. The clavicle can compress the brachial plexus, and so can a hypertonic or very, very tight pec minor muscle can compress this. And then it creates symptoms going down the arm, kind of like mimicking a carpal tunnel type of issue. And that's why when people experience symptoms in the hand, the problem may be the hand, but it can also be way up here in the neck. You can have nerve impingements in the neck, in the shoulder, or in the elbow that refer pain into the fingers. Remember, when you step on a dog's tail, the dog barks at the mouth at the other end. So the axillary nerve controls the deltoid and the teres minor muscle. The musculocutaneous controls the elbow flexors. So review what the elbow flexors are. Remember the biceps brachii, the brachialis, those are the main elbow flexors. The radial nerve goes to the shoulder and the elbow and the wrist extensor. So anything that deals with extension from the shoulder, the elbow, and even the wrist and the fingers, they're going to be radial nerve. And the median nerve and the ulnar nerve are going to go with the flexors of the wrist and the hand. Okay, most of them are median nerve except for 1.5 muscle. There's only 1.5 muscles that are innervated by the ulnar nerve, and that's going to be the flexor carpi ulnaris and half of the flexor digitorum profundus. And the half of the flexor digitorum profundus will be the half that go to digits 4 and 5. Flexor digitorum profundus for digits 2 and 3, they're going to be median nerve. But the ulnar nerve goes to digits 4 and 5 of the flexor digitorum profundus and the flexor carpi ulnaris. All other flexors are going to be median nerve. So again, when you take a look at the brachial plexus, we'll see it goes from C5, 6, 7, 8, and T1. Those are the nerve roots. And then we have trunks, and we have divisions, and we have cords. But at the very end, we're focusing on these branches, the ones in red. Primarily the musculocutaneous, the axillary, the median nerve, the radian nerve, and the ulnar nerve. So we have 1, 2, 3, 4. Those are the five terminal branches. Now, when we have damage to parts of the brachial nerve, it can create some clinical conditions. So I figured it's kind of important to review some of these. And I call it Dr. Kuma. Dr. Kuma. What I'm circling applies to the nerve. So R is for radial nerve, U is for ulnar nerve, and M is for median nerve. So DR is when the radial nerve gets damaged, you can get drop hand, which looks like this. And that's because the radial nerve extends the wrist and the fingers. So if there's damage to the radial nerve, the flexors kick in and the extensors are weak, so you get this wrist drop position. Okay, that's wrist drop. Median nerve injury, which is here, you get a condition called ape hand. And ape hand looks like here, where you kind of get this atrophy of all the thumb muscles. And what separates us from monkeys and gorillas is the use of the opposable thumb. Okay, that's a big difference. So when there's damage to the median nerve, we get ape hand, which is atrophy of all the thumb muscles. You get claw hand with ulnar nerve damage, which is here. Sometimes they call it bishop's hand. But what ends up happening is when there's ulnar nerve damage, you get this inability, the fourth and the fifth digit, the knuckles, these parts come up in extension, but the fingers curl down. And that's from ulnar nerve damage. It creates this claw. It's called claw hand. And you can get this from, let's say, compression along the pisiform, let's say long distance bikers, people that lean on the pisiform too long on a desk. This could be damaged. Karate chops where you damage that ulnar nerve. All of that can create ulnar nerve palsy or claw hand. So drop wrist is radial nerve damage, claw hand is ulnar nerve damage, ape hand is median nerve damage. Here we have SALT, S-A-L-T. When the serratus anterior muscle is affected, it's usually due to the long thoracic nerve. So LT, long thoracic nerve damage, gives you winging of the scapula. You notice how the vertebral border wings away when you push up against the wall, and the vertebral border wings and flares away from the rib cage. It's long thoracic nerve damage, serratus anterior muscle weakness, winging of the scapula. In terms of the peripheral nerves, besides controlling muscles, there's a sensory component to it. Now, the median nerve, which is involved with carpal tunnel syndrome, affects 1, 2, 3, and half of the ring finger. Okay, the median nerve on the anterior side is the first, second, third, and half of the ring finger. The half that's closest to the other 3, obviously. And also 1, 2, 3, and half of the ring finger on the dorsal side, but more of the tips. Okay. The radial nerve does 1, 2, 3, and half of the ring on the dorsal side, but more proximal. And the ulnar nerve gets what's left. It's half of the ring and the pinky on both sides, the anterior and the posterior side. Okay, that's what we call cutaneous nerves. Not to be confused with dermatomes, because you can have problem with the neck and you can have a C6, C7, or C8 nerve root lesion in the neck. And when the thumb and the index finger have numbness and tingling, well, this could be a C6 issue. The middle digit could be, if it's numb and tingly, could be a C7 issue. And then these 2 fingers could be a C8 issue, nerve root issue. All right, so it could be coming from the neck, actually at the nerve roots themselves, or it could be peripherally the cutaneous nerves. Okay, when I come back, in the next video, we'll go over the lower back plexus.